Cool. So can I start? Can we go?
Yes.
Okay. I'm Lisa. I do palliative care and geriatrics and ethics at the VA. And I'm going to talk a little bit about CPR today for our geriatrics and palliative care grand rounds. And I realize, or the good Dr. Vendetta reminded me, that Katie O'Connell did the same topic about a year and a half ago. So there's that. But I think because one, I'm at the VA, and two, I'm not a trauma surgeon, I think it's going to be a little bit different, although there is some of the same material that Katie went over. So just, if you've heard it before, just bear with me. And if you haven't, that's cool too. All right, so to set the stage, I thought we'd just start with a little bit of prevalence, kind of to make the case that there's the potential for lots of people getting CPR out there. So this data shows us that about 200,000 people in the hospital have a cardiac arrest in the US each year, which is a lot. And the estimates are 350,000 outside the hospital. I suspect that's higher, but that's the number I could find. And because this is our geriatrics and palliative care grand rounds, here's some geriatric specific information. It seems like just about everywhere in the world, more older people are getting CPR. So a couple of things here. One, from Sweden, apparently the rate of people 90 and over getting CPR doubled over this 20-year period. And in Japan, the rate of people 80 and older getting CPR has also increased. So lots of old people potentially getting CPR. So what am I hoping to accomplish here? I'm hoping by the end of this, you all will be able to identify factors contributing to CPR being the default that we offer, be able to explain some of the different stakeholder perspectives on what CPR represents, and then be able to think a little bit about your own views about CPR. And how I'm going to do that. I'm going to start out with a definition and a little history of CPR because it's sort of fun and quirky, like me, I guess. And then we will talk about some of the factors that led to CPR being our default treatment, talk a little bit about some CPR outcomes, then focus on the different stakeholder perspectives around CPR, and talk a little bit about different approaches to addressing potentially inappropriate CPR. And a disclosure that this presentation is not going to resolve the dilemma of who should and shouldn't have CPR. And it's not going to make our moral distress around potentially inappropriate CPR go away. I'm not going to fix that. I'd love to, but I can't. But I'm hoping that maybe it will help us all understand the complexity of this a little more. So starting off with a definition of potentially inappropriate, which comes from this policy statement from all these different medical groups. So they all got together and agreed on it. And since I have you guys' picture, I can't see my slides all the way across, so I'm just going to read this. Sorry about the noise. Okay, so the term potentially inappropriate should be used rather than futile to describe treatments that have at least some chance of accomplishing the effect sought by the patient, but clinicians believe that competing ethical considerations justify not providing them. So that's what we're going to mean when we talk about potentially inappropriate. And it says not to use futile, but I do have that word in these slides a little bit, just to acknowledge that. Okay, so let's get in our time machine and go back in time, okay? So here's a little history of CPR, which I thought was fun. So apparently, In the 1530s, that's a long time ago, there was a Swiss physician who used bellows to the nostril to revive somebody. And then we jump a couple hundred years to 1732, when there was a Scottish physician who used mouth to mouth to revive a suffocated coal miner. And then a few years later, the Académie des Sciences, that's French, recommended mouth to mouth to revive drowning victims. And then we keep going. So in 1901, there was a successful intraoperative open chest cardiac massage performed. I think they wrote about it in JAMA or something. And then in the 1960s is when the CPR we sort of recognized became more widely used. So in the 1960s, they developed closed compression for anesthesia-induced arrests with the addition of mouth to mouth. So I'm going to emphasize that. Anesthesia-induced arrest. So when CPR was first being used, it was in the OR setting for patients who were deemed well enough to have surgery and had some kind of, reaction potentially to some of the medications that were used. So I think keeping that in mind to see where we've gone from there is important. And I think it's really cool. You can just Google and find a picture of a 1960s OR. So there you have it. You can also Google 1970s ambulances, which kind of look like hearses, but there's one for you. So in the 1970s in Seattle, 100,000 citizens were taught to provide CPR in the community. So all of a sudden, we have moved from the ORs to everywhere in the world, right? And understandably, there's a lot of excitement about the potential to save people, but CPR is now going to be delivered to a way more heterogeneous group. And if you have lay citizens out there providing CPR, they are not going to be assessing the chances of success, right? They go to the grocery store, there's somebody down, they know how to do CPR. They're not going to figure out that that person has metastatic cancer, is on hospice, etc. So everybody is doing CPR, right? So even now, if King Charles drops dead, Camilla knows how to do CPR, although she's not quite in the right location, but that's okay. But maybe she can bring him back so he can be king for a little longer. And look how much fun it is, right? So you have all these people trained up to do CPR all over the place. So no wonder it's sort of being offered everywhere. So that sort of gets us to our next topic of how did CPR become the default? And so there are different theories about this. I think one of them is because so many people out there can do lay CPR, it's sort of assumed that that's what's going to be offered, right? Another factor is that in the US, as you know, we're very focused on autonomy. And so I think many people, when given the option of something that might keep them from being dead, want that treatment. And then there's some other factors that I'm going to talk a little bit more about. So CPR survival on TV, there have been a few of these studies now. This is one from 2015, where the researchers watched a whole bunch of TV, watched 91 different medical dramas, found that in those 91 episodes, there were 46 instances where CPR was needed, and the survival from that was about 70%, which, as you guys know, is a little higher than in the real world. And then of those 70% who survived, about 72% of those people survived to hospital discharge. So again, very high numbers. And if our patients are getting their information from TV, this is going to influence it. And because this is our geriatrics and palliative care grand rounds, a lot of old people aren't so tech savvy, so they watch a lot of TV. Okay, next factor, legal influences. So there's EMTALA, which is the emergency medical treatment, and I can't see the end of my slides, and Labor Act. And it's basically a sort of an anti-dumping law saying that if somebody shows up in your ER and they're unstable, you have to stabilize them before you ship them out. And so for the pediatricians on the call, there's a relevant pediatric thing, which I think you probably know better than the rest of us, but the baby K case, which was a baby born with anencephaly, who was thought was going to die soon, didn't, went to some kind of nursing home and was sent back to the hospital from the nursing home a few times with, I think, respiratory problems. And the doctors were arguing that when this infant showed up in the ER, there should be an exception to EMTALA because of the kid's situation. And the court ruled that, nope, there is not an exception. So people felt like, somebody shows up in the ER, needs CPR, we have to provide it. And then one more legal influence. So in New York State, and I don't know what other states have this, but in New York State, you cannot write a unilateral DNR order. So like many things in geriatrics, how CPR became a default is multifactorial. Okay, so let's move on to the next topic, which is outcomes of CPR. And I think, different patients, as we all know, are going to value different things. And so I have sort of different functional and cognitive statuses there. Unfortunately, there's not a lot of data on functional or eventual functional outcomes after CPR, but let's talk about some of the data that is out there. So let's look at the percent survival to hospital discharge after CPR in adults in 2020. So if you're hospitalized when you have your arrest, about 23% survive to hospital discharge, versus if you're out in the community and like Camilla finds you, you only have a 9% chance of survival to hospital discharge. And so when I first saw this, I thought to myself, ooh, 23%, that's really pretty good, which I guess it is, but that means that over 75% don't make it, which is a pretty high number. If you look at survival to hospital discharge in different racial and ethnic groups, unfortunately, there are health disparities here, like just about everything else that we're finding. So I put that out there for you. And then because this is our geriatrics and palliative care ground rounds, let's look at older age. And there are different studies out there. These are just a couple of them. One, because it was in Seattle. So a study of 12,000 EMS treated patients, and they found that each year of age, when you're an adult, so not like a kid, but adults, is associated with a lower likelihood of survival. And then the Swedish study that looked at not survival to hospital discharge, but 30-day survival in people 70 and older. And you can see that the percent of people who do survive to 30 days goes down as they get older. And then frailty. What about frailty? So there's this recent study that pooled data from 3 other studies that had looked at in-hospital cardiac arrests, and they found that the mean age of people was 71, and that the presence of frailty was associated with a 3-fold increase in your odds of dying in the hospital. So yeah, being older and being frail does not bode well for doing well after CPR. And then there's also this issue of your neurologic function. So you might be alive, but what kind of state are you going to be in? And is it going to be worth it to you? So this is an older study, I realize, but it looked at sort of neurologic function after in-hospital CPR in older people, well, in all kinds of ages, but they sort of divided it out this way. And you can see that if you are 85 or older in the hospital and you have an arrest, about 4.5% of that group is going to survive with good neurologic function. So that is pretty darn low.
Oh, could I ask a question about this
Yeah.
data?
Oh boy.
Yeah. So do we know what percent of people had a good neurological function prior to CPR?
Oh, I think they had some of that, but I can't rattle off the data. You can look at the study.
Yeah.
But that's a
I mean,
good.
obviously, if only 20% of less than 70,
Mhm,
you know, so we need one more number, really, I think.
mhm. Yeah, and this study was set up to like develop this instrument. So the data is presented in sort of a funky way. Just to warn you. Okay. So looking at all of that, I would argue that CPR outcomes aren't great, but are the outcomes worse than the outcomes of some other interventions that are offered to patients? And if the alternative is death, I think for some patients and family, a 5% chance of success may be worth it. So let's keep going. So when we're talking to people about CPR, we often want to find out for them what's an acceptable quality of life. And, you know, as we all know, for different people, it's very different. So I thought we'd do something a little fun. Hopefully you guys are up for participating. So we're going to do a little poll and make a little word cloud about what makes life worth living for you. So what you can do is, if you're on a computer, you can use your phone to get this QR code and then put in one word. If you want to put in more than one word, just put a comma between them so the system identifies it. And if you're on your phone, what you can do is take a picture of this QR code, and then you go to your photos and you go down to the little, well, on an iPhone, you go down to the place where like you're going to send it in a text to a friend. And if you go down and you can find something that says Google, you can click on that. And that'll get you to the system. Okay, so it looks like 7 people are putting stuff in. Thank you guys for humoring me. And if you, once you've put it in, you can sort of see, because I'm behind the VA firewall, I could not get this in the slides, although when a few more things come in, I am gonna put it down so you guys can, I'm gonna move what's coming through down. And thank you for humoring me with this. It's sort of fun. All right, here, I'm gonna bring it down. Well, you guys are saying some quirky, fun things. All right. So if I put this, if I move this down, can you guys see it? Or does it not work?
We're seeing responses on our phone.
Oh, but you're not seeing the responses on the screen. Oh, that's a bummer. I thought I could just move it down and you guys could see it. All right, we'll just keep looking at your phones then. And I got to move this back up so I can see my slides. Oh dear, now we have a problem. Oh goodness. Well, I screwed everything up, so I got to stop sharing and then start sharing again. That's what I get for trying to be high tech. Darn it. Okay, hopefully the slides are back.
Yep.
And with all of that, so what do you guys see on your phone? Because now I can't see any of it. Darn it.
Family.
Okay.
The word clouded on our phone.
Oh, I guess I could. Here, I could just zap it and get it on my phone and then I can see.
Yeah. I see dogs, my children, helping others, peacefulness, independence, family, travel, vintage sport, community, forest, hiking,
Nice. Oh, you guys have
pizza,
got,
nature, food, friends, love.
thank you. Thank you for humoring me. And you guys totally didn't put in what I thought you would. That's fun too. So I thought people were going to put in things like being able to think straight, etc. But you didn't, which is good.
I did.
Oh, was somebody going to say something?
Yeah, I was saying I put the thinking straight.
Okay, so somebody did. Thank you. I thought many of you would, but anyway, because the point I was going to make is that for those of us working in healthcare, I think we often value our ability to sort of think straight, know what's going on more than others necessarily. But since that didn't come up, that's okay. We're just going to keep going. All right. But there is a bias out there towards valuing the life of people with intact cognitive abilities. And so I just give one example. This is a study from Switzerland where they looked at end-of-life decisions that were made for people with disabilities who were in residential homes. And they found that life-sustaining treatments were withheld in about a third of people with intellectual disabilities versus about 8% of people with other sort of physical disabilities. So I just put that there for you to think about. And so moving on, you know, if we think about our patients and their families, from their perspective, what makes life worth living? And the point I want to make is that there is a much broader range of accepted cognitive limitations, right? At the moment in the VA, we have a patient who has been at the VA in a persistent vegetative state for, I think, a couple of years, getting dialysis, and his family believes that his life is very much worth living and of value. I think many of us might not feel that way. Out there, you know, in the world, I think there's also a broader range of accepted functional limitations than within healthcare providers. And then there are the vitalists, who are a small segment of the population, but for them, you know, just being alive is worth it. So keep that in mind. And I contrast that with the clinician perspective, where, as I've already alluded to, I think we tend to value our cognitive abilities a bit more. And we also have a fairly homogeneous perspective on what we want at the end of life. So keep that in mind. There's also, our confidence in making futility determinations. So a case comes in, we determine that it's futile or it's potentially inappropriate to continue life-sustaining treatments, but how good are we really at this? And there are a few studies. Here's a more recent one. So this is a survey of attendings and fellows working in ICUs who were asked whether they were caring for any patients receiving futile care. Here are the reasons why they felt some of the patients they were taking care of, the cases were futile. So if the burdens grossly outweighed the benefits, if they felt like the person would never be able to survive outside the ICU, if the person was permanently unconscious, so there's the sort of cognitive bias, if the treatment cannot achieve the patient's goals, if it's felt that death is imminent, and if the patient is non-adherent to treatment. So then they looked at sort of survival of these patients. So of the patients receiving futile treatments, the percent who died during the hospitalization, so about half of the people that the fellows deemed the situations were futile died in the hospital, versus about 2/3 when the attendings made that determination. And then they continued to follow for 6 months, and they found that by 6 months, about 61% of the patients that the fellows felt their situations were futile had died, versus about 85% when the attendings had. So yeah, those numbers are high-ish, but it's not 100%. So this is where we're starting to get into sort of the trickiness of all of this. All right, I'm going to keep going. Next section. What does CPR represent? And so CPR is highly symbolic. And as this one ethicist wrote, it's a symbolic expression of a complex set of commitments. So if we think about the patient and family perspective, what might CPR represent for them? It might represent that the health system did not abandon their loved one or ration care to them. It may provide a reassurance that everything was really done for their loved one. And then it may represent that our voice was heard or respected, or that we matter. And that gets to be, that's sort of a big deal, I think, if that's what CPR means, that you as a person matter. And then there also may be a sense that allowing DNR is the same as killing a loved one, which is also emotionally pretty powerful. And I contrast that with the other side, with the clinician perspective. So what does a request for futile CPR represent to the clinician? It may represent that my medical knowledge is not believed or respected. My past experience with CPR doesn't matter. They don't get it. And then there's the issue that providing futile CPR is the same as torturing dying patients. So on both sides, there's a lot of emotion, and this sets us up for conflict between those two perspectives. And so I would argue that core values on both sides are threatened, and that this is a big deal. So on the patient and family side, there is the respect for my loved one's personhood or worth, and I won't kill my loved one. And on the other side, there is the respect for knowledge and experience, and I don't torture dying people. So you can see how on both sides, this is really emotionally laden. And it's a big deal because I think there is the risk for both sides experiencing moral injury. And moral injury occurs when one's deeply held moral beliefs are threatened by one's actions or inactions. And so I put this here because I think this kind of represents everything, right? People are on totally different planes. And how do you get everybody on the same page? It's going to be really difficult. So different groups, places, etc., have taken different approaches to try to manage requests for what clinicians believe is inappropriate CPR. So we're going to talk about these different factors, and I thought it would be fun. And this one you're not going to have to share, so you don't have to do it if you don't want. But I thought if you have a piece of paper, you can take a piece of paper, draw a line, paternalism over on the left, patient autonomy on the right. And as I go through these different potential solutions, just sort of figure out where you think they are on this continuum, and then you can see how they relate to each other. It's sort of fun, but if it's early in the morning and you don't want to do it, that's okay too. Okay, so Texas, and I know many of you have heard me say this before. So Texas has a state law about this, where it does allow unilateral DNRs and withdrawal of life-sustaining treatments for futility, but you have to go through these steps. First, there needs to be ethics consultation. Then you've got 10 days to find a different physician or hospital to accept your loved one. Courts can grant an extension. And after that, you can have a unilateral withdrawal of futile treatment. The problem is when they have looked at when the law is used, 61% of the patients have been African American. So if I start thinking health disparities, if I put on my ethics justice hat, then it's pretty obvious that everybody is not being treated the same. And that's not okay. So if you've got that piece of paper, you can just throw Texas on there somewhere. Okay, let's do the next one. Different hospital policies. So there are variations, even here in Seattle, which you will see. So some hospitals allow unilateral DNRs for futility, which is a best interests focus, and some don't, which is an autonomy focus. And Zhang wrote a really interesting piece about this, where she found that clinicians' views of this whole issue are kind of influenced by the policies of the institution where they work. And so I'm at the VA, so I'm influenced by that. And at the VA, we cannot write unilateral DNR orders. However, within the last 5 years, the policy was updated, so it now has a paragraph that allows clinicians to make a clinical determination if CPR initiation or continuation is appropriate. So before that language, people at the VA felt like they had to do the full-on thing for everybody. At Harborview, there is the ability to write a unilateral DNR order. And I am thankful to my Harborview colleagues who shared the policy with me. And so an order may be written for a patient when the attending physician has made a determination that resuscitation would be potentially inappropriate or physiologically futile. So you can go back to your piece of paper and you can throw the VA's policy and the Harborview policy on there with Texas. And we'll move to the next one. So palliative care consults, you know, back in the olden days, now that I'm an old guy, I can say that, palliative care would sometimes get consulted to get the DNR. And as we all know, that's not really what we do. I mean, sometimes that comes out of it, but that's not our main intent in going in. I don't think this happens quite as much anymore, although those consulting us may have sort of a more nuanced way of asking for that. So you can put palliative care consultation on here as well. And we'll move to the next one. So informed assent. And what is that? That is where the patient and family are informed that CPR will not be performed. If the family disagrees, then the DNR order is not written. But there's the belief that doing this takes the decision-making burden off the patient and family. So that's another approach. And you can put that on here as well. Okay. And then the next one, slow codes. So what is a slow code? Here is one definition. A slow code involves initiating some resuscitative measures, but carrying them out slowly or omitting the most aggressive. Interventions in a slow code are limited in number, duration, intensity, or all three. In the ethics world, people have sort of weighed in on this issue and have actually weighed in on both sides of this issue, just so you know. So here are some of the groups who have weighed in that slow codes are not okay. So the American College of Physicians has written, because it is deceptive, physicians or nurses should not perform half-hearted resuscitation efforts. An ethics text wrote that slow codes are dishonest, crass dissimulation, and unethical. And a bioethicist has written that charades are not acceptable when it comes to life and death matters. So some of the opinions saying that slow codes are not okay. There's this article, though, that weighed in that slow codes are maybe sometimes okay. And the argument went like this, that slow codes might be appropriate when CPR is unlikely to be effective, the family accepts that death is inevitable, and yet the family is also unable to consent or assent to DNR. So I'm not going to weigh in, but just to sort of put all of that out there. But I am going to share a study about slow codes that came out last year. And so this is another survey of physicians, nurse practitioners, and nurses who work in medical or cardiac ICUs in Chicago. And of those who responded, 69% said they had cared for a patient who had a slow code. Now, you could argue that there's probably a bias in who responded, and that's probably true. But somewhere in Chicago, there are 69% of 230 some people who had participated in a slow code. And 52% felt that slow codes were ethical if they were medically futile, which kind of makes me think this. But I'm being a little sneaky. I haven't given you all the information. So of the 52%, 85% of them said that it was ethical, but that you had to inform the family that CPR was going to be limited. So that makes it sound a little less awful. And this one quote kind of highlights the tension. It is a way for the providers to follow patient or POA wishes without being cruel to the patient, right? So we want to honor the patient's preferences, but we also don't want to torture dying people, right? So there's this tension between the two. I also share this with you from that study where people weighed in on how morally distressing medically futile codes versus slow codes were. And so you can see that all the different groups, if you look over on the left, all the groups had less moral distress from conducting a slow code than from a medically futile code. So if you are playing this game, you can throw slow codes on there with the other things. Think about where that goes. All right, so this is what I came up with, although it's not perfect and we could have long arguments about where things should be. But I put this up there just to make the point that of the solutions out there, the majority of them are more skewed towards paternalism. So what do we do about this? And I don't have any brilliant solutions, but I just want to make a few more points to sort of give you some more things to think about. I'm almost done. So one, when palliative care or when ethics get consulted on these cases, often they've been going on for a while and everybody's already dug their heels in, and the two sides are already, often not often, but sometimes the clinician or the healthcare team side is starting to come up with negative reasons why the family may be acting this way, versus taking the time to sort of sit down and really understand where they're coming from. Within healthcare, we often will jump to the conclusion that suffering is bad. We had a recent awful case in our ICU where many of the nurses were really concerned about the patient's suffering. This patient was sort of an old school Catholic. And so our Catholic chaplain offered this, which didn't reduce anyone's distress, but I think is important to remember that in Catholicism, there is a concept called redemptive. Hey, May, put yourself on mute. There's a concept called redemptive suffering, whereby are were you going to say something, May, or are you talking to other people?
Sorry.
Okay. Our experience of suffering is an act of purification that helps us both to grow spiritually in this life and to prepare us for the life to come. This contradicts the notion that suffering is bad and must be eliminated. Suffering is part of the human condition, and while it cannot be cured, it can and should be managed insofar as possible. So yeah, if there are things we can do to prevent suffering, that's great, but suffering isn't necessarily always bad. And then many of you have heard me mention this before, but I'll put it up here for those who haven't heard, because this piece, I think, is fairly powerful in making the case that in some situations, performing what we think is futile CPR is actually the right thing to do. And for the pediatricians on the call, this is another pediatric case. But I encourage you to look at this piece. And I have copies. I'm happy to send them to whoever. I think another thing we can do within that policy statement, they had these 4 questions that we can think about when we're trying to determine if something really is potentially inappropriate or not. So here are the questions. So 1, am I certain that this requested treatment is outside of the boundaries of accepted practice? 2, would I be willing to have the rationale for my decision publicly reviewed in an appeals board or court? 3, what are the consequences to the patient, surrogate, team, or institution as a result of implementing this decision? And 4, am I sure that sex, race, socioeconomic status, ability to pay, or other psychosocial factors are not entering into my decision? So I think this kind of captures this whole situation, right? It's complicated and it's messy and there's no good solution. So I'm going to end, but the take-home points are that CPR ending up as the default is probably multifactorial. CPR outcomes aren't great, but some patients and families are probably willing to take that small % chance of success. I hope I have highlighted the tension between stakeholders and made the point that people's sort of core values are threatened, which makes it really hard to sort of get everybody on the same page. Most of the solutions to the issue of potentially inappropriate treatment are more paternalistic. Futile CPR does cause clinician moral distress, but in some cases it actually may be appreciated by the families. And then suffering isn't always a bad thing. So I'm going to end there. Oh yeah, I got to show you guys the QR code for the evaluations. So if you can submit the evaluations, that would be great. And I will open it up to questions and comments. And I see a whole bunch of stuff came in the chat that I couldn't see while I was talking. I'm sorry. So any thoughts? And I realize that everyone isn't going to agree with this. That's the fun of ethics, is not everybody agrees. Yes, Wayne, I think you have your hand up.
I do. Thank you. Good job, Lisa. That was good talk. I was going to say something about CPR as a medical therapy that's indicated or not. You know, in the hospital, we don't just do CPR, we do ACLS, you know, the whole 9 yards. And, you know, we don't give rituximab for acne or hemodialysis for constipation. So I'm wondering if we might, over time, since it's getting more paternalistic in your analysis, we might move to a space where CPR isn't thought of as futile or inappropriate, or what, it's either indicated or not.
Mm-hmm.
And I mean, we give therapies that, you know, kind of aren't indicated all the time if we're wrong about the diagnosis or whatnot. It's not like that's a rare thing.
Mm-hmm.
But that's a reframing, a semantic reframing, but it may make things worse. And then I had an experience a couple of years ago that's only happened to me a couple of times in my career, and that is where family members were present for ACLS therapy, which is a very cathartic experience for all concerned. But the 2 times I've had that, the family expressed gratitude for having personally witnessed ACLS therapy, including CPR. So kind of lending credence to your final points about
Right,
sometimes.
and there's at least one, maybe there's more than one study of families who witness CPR, and they actually do better if they have witnessed it, which sort of the first time I saw that kind of surprised me. I thought, really, seeing all that awful stuff happen, they had better outcomes, but they did. So that sort of fits with what you're saying, Wayne. David.
Yeah, just following up on Wayne's point, it seems like I'm just thinking about the slide that showed that 100% of nurses who were involved in cases of CPR deemed futile were distressed by it. And that really concerns me. And it suggests that we need to do a better job of supporting our nurse colleagues, especially in how we think about this and in reframing CPR as, in some cases, a therapeutic procedure for the family. And perhaps that is a way through some of the staff moral distress questions. And moral distress, as I understand the definition, means that we know the right thing to do, but we are prevented from doing it. And
Yep.
so reframing around what actually is the right thing to do seems a very important part of this whole discussion. And if we are stuck in a situation where we believe that we are torturing patients and that there is no good to be gained by doing this, we're going to continue to have 100% moral distress from bedside nurses. And we have got to change that dynamic somehow.
Yep. Yeah, no, I don't think anyone has quite figured out how to do that yet. But I think you make a really good point, David, that like trying to shift people's sort of perspective taking on all of this. Oh, Pam Davies, how nice to see you. You have a comment.
Hi, Lisa. I always love your talks. So thank you. I don't know if you can see the chat, but Lauren, Amy, and I all put something in about healthcare costs and considering that. I mean, one of your last slides, made a comment about a person's ability to pay, but I think in the US especially, we're just so focused on autonomy and we're not looking at the big picture. If somebody ends up being resuscitated and they're in a persistent vegetative state and then they end up Medicare, Medicaid pays for them for years in a nursing home, as Lauren points out, that's money that could be used for chronic disease prevention. I'm interested in your perspective from an ethical point of view of by benefiting in quotes, one person that we could, if we didn't do futile CPR, we might be able to benefit many in the population.
Well, and that's sort of the whole utilitarian argument, right? Is and there are sort of pros and cons of utilitarianism as well. And I guess I'm kind of thankful that I'm at the VA, which is a different system with sort of a different payment system. So I don't sort of often think or worry about as much about that stuff. So I appreciate you guys.
Costs involved. I mean, there's
Yeah.
costs.
Right. Oh, yeah. And we all pay taxes. So we're all sort of paying towards this guy in the persistent vegetative state being in the VA for 2 years. Sarah, you have your hand up.
I just learned how to use that function. I feel very tech savvy today. Yes, it's taken me a while. I have a question. I don't know if it's a fully formed question on slow codes, which I think are interesting. And I wonder if this would also count as a slow code if you set a limit to resuscitation, like we're going to give you 3 rounds of ACLS and it's wholehearted resuscitation during those 3 rounds, but you set limits both for the sake of patient suffering and resource utilization and maybe low resource areas about blood products and space. I'm just curious, like how that fits in, and is that unethical, or is it a way to balance this concept of distress and family values? Just curious. It's also very thought provoking, like as a talk that you gave, because like Tiffany and I are sitting here and we've been chatting the whole time about things that have come up. So it's been a successful talk.
Yeah, and I don't think I have the answer. I think negotiating to 3 rounds of CPR seems even more menu-y than like, I want the CPR and I don't want the intubation, and yeah, maybe I'll do dialysis, but no, I don't want that, which gets sort of messy. I think the other point is that in terms of rationing care, rationing needs to be made at sort of the policy institution or even above institution level, not at the individual level, right? Because as we saw in like Hurricane Katrina in New Orleans, the clinicians made individual rationing decisions. And at the time, I think they thought they were doing the right thing. But then in retrospect, we look back and we say, oh my God, you like offed all these people just because they were DNR. That's not okay. So that doesn't really answer your question, but I just put that out there.
I appreciate it as like more things to mull on.
And hi, Lisa, this is Isabella. I guess
Yeah.
just one more thing for us to think about, also no answers, but when we talk about like slow codes and we let people see these kinds of things, right? If there is a family member close by, I think it also leads to more wanting in the future to decide for themselves, like, I want CPR, but I don't want intubation, or like picking and choosing like a menu when in reality it can't be done. I have found helpful for me and like, the teams that I work with that explain it as it's a medical procedure and it's an all or nothing kind of thing. And I don't know, like I haven't studied it, but like for the people that I work with, for the residents, usually when we talk about it in this way, it seems to decrease the distress about doing things. Like it's a medical procedure, we either do it or we don't, versus, doing parts of it slowly, because then it gets more confusing for everyone. I guess, I don't know, it would be good to know nowadays if it actually helps to do parts of it, but.
Yeah. Thank you. Katie, you've got your hand up.
Hi, Lisa. Thank you so much for that talk. This is a topic that I think about a lot.
And you've talked about.
Yeah. It stems from the fact that I never received any training of how to talk about this with patients and families. And I don't think it really exists today within surgery training. And so this default of just, well, I asked them what they want and we're full code. One of the things that I wanted to bring up is my experience with having been involved with several patients who had explicit discussions. DNR was decided, they died in the hospital and received CPR. And I think oftentimes like that perspective is kind of left out of these conversations in terms of this blanket default of full code, in my mind, is paternalistic, because we're now applying it to people who it was never developed to benefit. So people who have multi-system organ failure, who have underlying frailty, all the not just the isolated acute cardiac event people. And so I wonder kind of how you feel about that in terms of it. So different, my framework has kind of shifted over the years because of those instances.
Yeah, no, and I think we all have sort of different perspectives on this and different opinions. And, as I hope I've showed, like even in the literature, it's not clear that one or the other is the right, but it is clear that clinicians and especially nurses have a lot of moral distress over all of these situations where some of them may be appropriate. And so how do we, I don't have any solutions, sadly, on how we sort of move everybody to sort of get on the same page. To your point, Katie, there there was a New York Times article not that long ago about patients who wanted to be DNR, who received CPR, who then went on and sued. So it's not, you know, and at the VA, we're struggling with this whole like DNR wristband thing. And is that sort of an adjunct to really make sure that patients who want to be DNR don't get resuscitated? And that's a whole nother hour talk on without any good solutions, unfortunately. But in ethics, there are a lot of things that are really complicated and there's no good solution, I'm finding. We talk about this in our ethics committee a lot, which, you know, I guess we always want good solutions, but at this point in time, there really isn't anything. Oh, and we're over. I'm sorry, you guys. Maybe we should move on to the division meeting, which is apparently, oh, Shanitra, are you still there? Do you want to pop on and tell us? Because there were two different Zoom links for the division meeting. So to ensure that we pop onto the same one.
Hello, I'm all here. I just posted the correct link,
Oh,
so we can end now, and then I'll see you all in
And
just
it's
a
in the
moment.
chat.
It's in the chat.
Okay, I'm going to the chat. Thanks, everybody.
Thanks, everyone.